So we chose a pediatric case of an 8-year-old boy with an enlarging mass in his right breast. I'm Mara.
I'm Kate.
So the patient in this case was an 8-year-old boy who had a growing mass under his right areola. This mass was noted during a routine annual examination a week before he came to the hospital. And this mass was noted to be round, mobile, and not associated with any sort of discharge. The mass had been present for approximately 18 months according to his parents, but had enlarged more in the recent months. And it was at this point that he was referred to a pediatric endocrinology clinic. His medical history, he had a very normal history for growth and development. The only medications he was on was a topical triamcinolone for his eczema, and all of his childhood vaccines were current. He lived with his father, mother, and younger sibling, all of whom were healthy, and he was in second grade and a pretty normal second grader in school and everything. The one kind of funky thing in his medical history was his paternal grandmother did have a history of breast cancer, which had been diagnosed around age 70.
So upon examination, again, besides the mass, he was a fairly healthy child. He had no dysmorphic features, which means that everything else was normally sized and shaped. His height and weight were normal in the 68th and 72nd percentile, respectively. He had a little bit of fine pubic hair present, and his testes had a volume of about 3 milliliters. His phallus was prepubertal, and the bones in his hand were consistent of those in an 8-year-old child. The first test that was performed was just a simple ultrasound on the mass itself, which revealed that the mass was 1.4 centimeters by 1.3 centimeters by 0.8 centimeters, and that it was oval-shaped and not attached to the skin. It showed that it had smooth peripheral margins, and it was superficial to the pectoralis muscle.
So the first diagnostic consideration for this patient, because he was a male with breast enlargement, was gynecomastia. And true gynecomastia is the growth of glandular tissue in the breast area. And when considering true gynecomastia, it's always really important to first consider possible pseudogynecomastia, which is shown here on the right. And the difference between gynecomastia and pseudogynecomastia is where you can see this kind of a growth of the glandular tissue right there in the true gynecomastia. In the pseudogynecomastia, it's simply fatty tissue. So pseudogynecomastia usually occurs in obese patients and is almost always bilateral. And so they were able to discount this as the possible source because the patient had a normal BMI and his mass was unilateral, so it didn't really make sense for it to be pseudogynecomastia. Gynecomastia can be physiologic or pathologic, and so they looked into physiological pubertal gynecomastia, which occurs when the estrogen levels reach adult level while the androgen levels are still in pubertal levels, and that leads to the growth of glandular tissue in the breast. This occurs in approximately 65% of boys. It's very common. Usually it peaks around ages 13, 14, and it regresses spontaneously in 90% of those affected. This seemed unlikely to be his diagnosis, though, because he was not yet in true puberty. He was 8 years old, and all of his hormone and physical signs did not suggest that he had began true puberty yet.
So gynecomastia can also be caused by an exposure to herbal compounds or drugs, including estrogen and estrogen compounds, drugs that increase endogenous estrogen production, and drugs that prevent testosterone production and action. However, the patient hadn't been exposed to any such substance, so this couldn't be the cause of the mass. And it can also be caused by decreased testosterone secretion action. And this occurs when testosterone levels decrease while estrogen levels remain normal. And this usually occurs in boys beyond the age of 14 who are beyond the age of the start of puberty. And it can occur based on several of these conditions. However, none of the features of microphallus or pituitary hormone deficiencies were present in this patient. And based on his medical history, examination, and his normal follicle-stimulating hormone and luteinizing hormone levels, none of these causes of hypogonadotrophic hypogonadism were the cause of the mass. And it can also be caused by an increase in estrogen production, by, again, all these conditions. All of these except for ovotesticular disorder are hormonal conditions, Ovotesticular disorder is when there are both testicular and ovarian tissue present in an individual. However, the patient had no testicular asymmetry, which rules out ovotesticular disorder as the cause of the mass, and he had normal HCG, gonadotrophin, and estriadol levels. His genitalia was unambiguous, and he lacked the phenotypic and biochemical profiles that would suggest any of these other conditions. Another possible diagnosis would be a benign breast lesion, which are extremely rare in children, and they can include breast abscesses, intraductal cysts and papillomas, fibroadenomas, and phyllodes tumors. However, these are all characterized by some form of discharge, rapid growth, and inflammation. However, the patient didn't report any sort of inflammation or discharge from his nipples, and the mass did not grow very rapidly, which again rules out these as the cause of the mass.
The final diagnostic consideration for this patient was breast cancer, which is again extremely rare in children. It only makes up approximately 0.1 to 0.3% of all breast cancers. And the majority of these childhood breast cancers are secretory carcinomas, which is a fairly slow-growing cancer and usually ends up having a fairly good prognosis. But a more common cancer-related possible diagnosis for this would have been the metastases from other cancers from other parts of the body that have grown and expanded and have reached the breast tissue. But despite how rare breast cancer is in children, it still remained the most likely diagnosis due to the extensive negative endocrinological evaluations that were done. And so because of this, the patient was then referred to the pediatric surgeon because they were worried that he could potentially have breast cancer or some other form of cancer. At this point, a biopsy was performed. An incision was made at the junction of the areola and the skin, and this biopsy revealed that the skin had not yet been infiltrated by the mass. The mass had a texture of rubbery to firm. It measured approximately 1.8 centimeters by 1.2 centimeters by 0.8 centimeters, so very similar to their approximations before. The mass was well circumscribed and did not extend into deep muscle. At this point, the excised mass was submitted for some additional examinations.
So after the biopsy, there were quite a few additional tests performed, including a microscopic examination, a cytologic examination, acid shift staining, diastase, immunohistological staining, fluorescence, and a dual color break-apart FISH test. However, there are only some of these that were really important for the diagnosis, which ended up being a secretory carcinoma in the breast. One of the more important ones was the microscopic examination, which showed that the mass was well-defined and that it was composed of invasive ductal carcinoma. It also showed a predominant solid growth pattern with interspersed fibrous septa, which is shown in this picture, and a minor microcystic and microglandular pattern. Another one of the more important tests was the cytologic examination, which showed that the cells had pale to pink cytoplasms. It contained small round nuclei and small nucleoli. It open chromatin. That the tumor cells, the gland lumina, and the microcystic spaces contained amphophilic and eosinophilic secretions. That there's a slight mitotic activity in the tumor. There's no lymphovascular invasion, and most importantly here is that the ductal carcinoma in situ had identical cytomorphological features to the invasive ductal carcinoma in the excision specimen. And so the top picture here shows the tumor cells with the small round nuclei and the pale to pink cytoplasm. And the bottom picture shows the tumor cells, the gland, lumina, and the microcystic spaces that contained the secretions and also lacked glycogen. So then, probably the coolest test they performed is the dual color break-apart fluorescence in situ hybridization, or FISH. And the way this test works is it's largely done on cancer cells. And so they insert, so the way also they tell the cells apart, they make sure they're only doing it on cancer cells, is so normal cells, if they've been invaded by a foreign source, they'll present an antigen on their surface, which prompts the immune system to eliminate them, whereas cancer cells obviously get around that. And so they still have a specific antigen on their surface. And in this particular test, they did is they marked, there's a specific gene they were looking for to confirm the diagnosis of a specific translocation that's specific to secretory carcinomas. And so here they applied a substance that made the 3' end of the desired gene, which in this case was the NTRK3 gene, glow red, while the 5' end glowed green under fluorescence. And those are pointed out by the arrows in the diagram.
So because of all of these tests, they were able to diagnose the patient with a secretory carcinoma. And again, as we talked before, breast cancer is extremely rare in children, so there wasn't a lot of literature on the topic. So they ended up talking with some of the breast oncology people in the hospital and their colleagues when they were discussing the treatment of this patient. And the suggested initial treatment for this was a local excision. But due to the fact that during the excisional biopsy, it was noticed that the tumor had positive margins, meaning the tumor cancer cells had started to grow outside of the tumor. They decided that a mastectomy was necessary to remove all cancerous tissue, which meant basically they removed the entire breast, all the skin, the subcutaneous tissue, the muscle fascia, while sparing the muscle. And after this, they performed a sentinel lymph node biopsy to make sure that the cancer metastasis had not gone further into the body into the local lymph nodes. And through this, they were able to note that that had not happened yet, which was a very good sign for the patient. And because of this, they were able to bypass adjuvant therapy and radiation therapy, which was especially good considering the patient was a child, because the radiation therapy can inhibit the normal growth of musculoskeletal tissue, and it can also lead to increased risk of the development of an additional primary cancer, which in a child are all larger risks. They have much more life left in which they could possibly get a cancer, so you don't want to have to give a child radiation therapy if you don't have to. And relapses of this are fairly uncommon and usually occur at the local site within the first few years. So for the first year, they had follow-up appointments every 3 months, and the next 2 years, every 6 months. And as of that 3 years post-op point, this patient was still doing well and was healthy and had had no reoccurrences. And they plan on seeing him annually from this point on. These checkups consisted of a physical examination, and they monitored the serum levels of the cancer marker, and those levels remained normal and stable ever since the surgery. Unfortunately, they aren't able to compare them to levels before because those levels were not taken. But as of this point, the boy is doing well and is healthy, and overall a happy ending.
This is obviously extremely rare. In practicing surgery for 25 years, I only treated one adult male with breast cancer. Never even heard of this before. So do you know what the incidence is, or did they state per 100,000 or people or whatever?
No, they didn't. But the biggest thing was just that only about like 0.1 to 0.3, which wasn't even a full percentage of them happen in children. So I can't imagine how small the number is for male children.
The other thing is, did they mention anything about the other breast?
Nothing besides that it was normal.
Because if this were an adult, of course, there would be the possibility of a prophylactic mastectomy, in other words, remove the breast tissue from the opposite side, which in a male is really no big deal.
Mm-hmm.
So if I were a parent, it would be something I'd be kind of curious about. I was wondering if they mentioned that.
I don't think they really mentioned it beyond just like they didn't do that, so I'm not sure exactly why.
Even with no occurrence in the sentinel in the
Right, because the opposite breast presumably has the same genetic material as the one which became affected, and so who knows what triggered it in the right breast, so it might accrue in the other side, so why not just remove it and not worry about it?
Certainly, I think what's interesting about this case, this is the second talk about breast cancer we've had today, and how totally differently these cases were managed between the woman with, all the students came in late for that talk, but the first talk was about a mentally ill patient, a woman, and how hard it was to treat her breast cancer. And they gave her a lumpectomy, which is essentially what they did to this kid to start with. They cut the lump out, but then they did margins and they turned up positive. They took the boy's entire tissue out. They did all these fancy immunohistologic assays. But, with a person with mental illness, it's much harder to manage that. That's kind of interesting comparison. Okay, any other questions?